Good evening, everyone. So, today evening we have gathered to learn about one of the menaces that presents to the emergency department of any hospital every day, and that is management of dog bite. As far as India is concerned, we declare around 180 to 210 cases of rabies every year. So firstly, this slide is made for information, education and communication purposes and is meant strictly for medical professionals. Majority of its contents are derived from National Rabies Control Program under Ministry of Health and Family Welfare. The motto of National Rabies Control Program is 0 by 30, that is 0 cases of dog mediated rabies by 2030. So how do we achieve that? We achieve that by educating our young medical officers, paramedical staff. So that is the main purpose of giving this presentation. So what is rabies? Rabies is a fatal meningoencephalitis caused by Lysa virus. It is 100% fatal. The presentation is with change of behavior, aerophobia, hydrophobia. We have been seeing enough number of cases floating throughout the social media as to how people are catching rabies, and a few cases which just now crept up that people, despite being vaccinated or being given active immunization, people still presented with rabies and lost their life. So this causes one of the most painful deaths ever that a medico can ever witness. So the first question is कि bites of what all animal can cause rabies. Like in India, rabies is an endemic where we have shown dog to dog transmissions are existing already in nature. So in such kind of a scenario, bites by all warm-blooded animal are to be considered potentially a bite by a rabid animal. Bites by all warm-blooded animal. Exposure to wild animals are not only to be considered exposure to a rabid animal, but also to be considered in category 3. We will come to that. What is category 3 of dog bite? Category 3 bites. Exposure to domestic rodents. Once again, domestic rodents should also be considered a rabid animal bite if the the place that the person resides is near to a forest area. However, for all general purposes, all the rodent bites are also to be considered warm animal bites. Exposure to bats. In India, there has been no documented cases of rabies whatsoever from bats. However, there remains a hell lot of possibility that bats may also cause rabies, so hence considered definite prophylaxis if exposure to caves or exposure to bat bites. Human to human transmission has still not been documented in India. However, in cases of organ transplant or exposure to fluids by a known case of a rabies patient, the person should be given prophylaxis. So now when we come to prophylaxis, when you are sitting at a hospital, the patient will come to you and will ask you, sir, can we observe the animal that has bitten me, or should the animal be observed? As per the latest norms, if a dog and a cat is found to be healthy at 10 days after the bite, it is very safe to assume that the dog or the cat is not infected by rabies virus. However, the studies of rabies in other animals are not yet established. The incubation period is not yet known. So hence, it has the observation of such animals are really not going to met out some very important data for management of such cases. So if the dog has been observed and dog has been found healthy at 10th day, so the individual comes to you at 10th day and asks me, ki, sir, the dog is found healthy, so can I stop the prophylaxis? Now I have already taken the 3 injections at 0, 3 and 7, so can I stop the prophylaxis? It is not recommended at my institution. I always prefer to give the full course of post-exposure prophylaxis. However, as per the National Rabies Prophylaxis Guideline 2019, if the person is already on the SN schedule, kindly skip over the next dose of the 14th day and convert it into a pre-exposure prophylaxis by giving the 4th dose on the 28th day. So another question comes ki, doctor, the dog that I have been bitten by or the cat that I have been bitten by is a very healthy animal and has been vaccinated properly as per the schedule. So do I still require to take the vaccine? The concept of a well vaccinated domestic pet does not exist in our country. Sorry to say that. The efficacy of animal vaccination depends upon, firstly, the technique, how the veterinarian has given the vaccine, and the anatomical side, the presence of fur on the animal, the depth of the injection, so the technique used, firstly. Secondly, the efficacy of the vaccine itself. Has the vaccine been stored and carried to the last point within the cold storage? We cannot ensure the human vaccines to be the cold chain has been maintained or not. So forget about the animal vaccination being done at with such an efficacy. Then the nutritional status of animal. The nutritional status of animal has a bearing upon the presence of or development of immunity in the animal. So the status of well vaccinated domestic pet does not exist in India. Second, the third question that an individual may ask, that the bite was by a provoked animal. I stepped on the tail and the dog bit me. The provocation again does not guarantee the dog is infected or not. So henceforth, the post-exposure prophylaxis is recommended for all. So now that we have come to a situation that the individual has been bitten. Now, how do we go about categorizing the bite? So, touching, feeding, licking on intact skin are class 1. Now, is contact of the intact skin with a known rabid animal or human case will again be considered category 1. If the dog, cat, mongoose, skunk, whatever the animal is, and it is a known rabid animal, it has died, and still if the secretions have come in contact with the skin, it is considered category 1. Category 2 is nibbling of uncovered skin. Nibbling is just taking small bites along with the saliva that has got onto the skin, and minor scratches and abrasions without breach in the skin or without drawing blood. No blood drawn, there has been bites, nibbling, then it will be considered category 2. Category 3 is any single or multiple transdermal bites drawing blood, licks on broken skin, and contamination of mucous membrane in the eyes, in the mouth. So these will be all considered category 3 bites. So how do we manage them? In 1, just wound management. In 2, wound management plus active immunization. In 3, wound management plus passive immunization plus active immunization. Anything that has drawn blood, contact with direct mucosa membrane, it becomes category 3. No doubts about that. You have to give passive immunization and active immunization both apart from the wound management. So how to treat such patient? Wound management is necessary for all categories. It is easy. It does not require anything except for running tap water. Again, when there has been a bite, the virus stays in the bite and it multiplies over there before it can go through the nerves, or there is an exoplasmic transportation of the virus ahead. So till the time the virus stays in the wound and it replicates in the wound. So the best part is removal of the virus at the bite site itself, and it is the most important part, and it is skipped in the majority of the clinics. It is the most important part of the treatment procedure. Any of these three categories, the wound management has to be there. Then active immunization is for category 1 and category 3. Passive immunization is for category 3 only. Active immunization is what? Active immunization is vaccination, so that the body develops the immunity against the virus. What is passive immunization? You already gives the antibody to the patient. Why are we giving, when we come and discuss the active immunization is about 5 shots of vaccine given over a period of 28 days. Why are we giving 5 shots? Because 1 shot is not enough. Body takes its own sweet time to develop the antibodies. So by the time the body takes over and develop the antibodies, how is the body going to fight this virus? The body can only fight this virus when you give some antibodies which has already been created in the laboratory, or which has been there in some other animals, and you have given the human body the antibodies. So the most important of all is the wound management part. So I will discuss in detail how do you go about the wound management. The wound management first is the removal of the virus. How do you remove the virus? You do it by firstly physical and then by the chemical means. What is the physical means? You see, there should be a hand wash area in the clinic. So you make the person wash the part of the body which has been bitten. After this has been washed, you should spend at least 15 minutes in washing the wounds. That is the recommended time. People do forget about the most important part. The viral load will die down just by this thing. And once you apply soap, it decreases the surface tension, it lyses the virus, it neutralizes the virus. So once you have to, even if the wound area is raw, you have to apply the soap water within the wounds and you have to clean it so that the virus dies or is removed by the flow of the water. After you have done that, then you come to the chemical neutralization part. Chemical neutralization is done by application of povidone iodine or alcohol on the wound. Alcohol will be painful, so just stick to povidone iodine ointment or solution. And then after this has been done, another one thing, in our country it is very this thing that when you go to the remotest area of the country, somebody said put chili powder, somebody says apply turmeric, lime, this all things, neem patta, this is not to be done at all. Just wash it with clean water, soap water, and then finally apply povidone iodine. It is good enough for decreasing or removal of all the viruses on the wound. After having done that, neutralization of the virus, after having done that, things not to be forgotten. Do not forget to give tetanus toxoid if the patient is not vaccinated against tetanus. Tetanus toxoid. Now what happens? A warm-blooded animal is bitten. So what do you expect? You expect all the flora that stays in the mouth of the animal to come in direct contact with the dermis. The skin has been breached, the epidermis has been breached. Now this thing. What all organism do you expect in that case? You expect Staph aureus, you expect Pasteurella, you expect anaerobic bacteria, you expect apart from this there can be strep epidermidis. So everything, of course, yeah, I forgot, Capnophagata, this is another organism that is found in the bite of cats. So this all organism will later lead to infection, so structured soft tissue infection, cellulitis. So you have to give antibiotic. CDC recommends antibiotic for bites by all warm-blooded animal. So what antibiotic do you give? In the penicillin group, you can give augmentin, give 625 milligram TDS. If you don't have augmentin or the patient is allergic to augmentin, then you can give moxifloxacin, 400 mg OD. If the bite has been very ghastly and there has been absolute devastation and there has been a lot of bleeding with soft tissue exposure, and you are thinking about giving injectables, then do opt for piperacillin tazobactam. Piperacillin tazobactam with clindamycin will form one of the best combinations for covering up both anaerobes as well as strep and this Pasteurella species. So now, better said than done. with domestication of all these terrier dogs, the hunter breed of dog, the shepherd dogs. Now, if you see those bites, they are very ghastly and very devastating, bringing, literally it causes degloving of the extremities. So, there is a hell lot of bleeding goes on if the wounds are on the face and all. So, better said, so how do you go about managing such devastating wound or such wounds which is already causing such amount of blood loss? Firstly is the suturing. The suturing has to be only done after rabies immunoglobulin has been infiltrated in the wound. Delay the suturing as far as possible. Sometimes it is said that 12 hours, sometimes it is said 24 hours, but delay. If you can delay, please delay the wound. So, use as minimal sutural threads as possible. Decrease the number or counts of the sutures that you are going to take. Then never tighten up the wound too tight. Leave some gap in between. The secondary suturing, leave some gap in between so that the ooze does come out. If there is at all a chance of being contaminated, getting contaminated with the virus or the bacteria, the ooze will definitely bring it out. So as minimal chance as possible. So now coming back to the passive immunization, how to give antibodies in a class 3 bite. The active immunization that we will give, that is the vaccine that we will give, it will take its own sweet time to act. In an ideal condition, a 3 doses of vaccine at 0, 3 and 7, this all start acting from 10 to 14 days in an ideal man who is not immunocompromised, who has proper immunity, proper nutrition. So for that time being, for 0 to 14 days, what will cover? It will be already the preformed antibodies that will inject within the wound. So the first thing that we talk about is ERIG. ERIG is equine rabies immunoglobulin. How it is found? It is a heterologous serum collected from hyperimmune horses. We have injected the horses with rabies virus at smaller doses. We have collected the homologous serum, filtered the homologous serum, purified it, got Fab2 fragments, and then we inject it. Maximum amount of dose has to be injected in near the wound. The amount of dosing in the other arm has proven to be of no benefit. So what you have to do is you have to take 40 IU per kg, because the half-life is less, because it will be destroyed much faster. So it requires a supramaximal dosing of 40 IU per kg, and it has to maximum has to be infiltrated near the wound. The second we come to the autologous serum, the human serum. Again, though it has been collected from a pool of donors, pool of human donors, so and it has been purified by various measures, but still there are negligible chances that some amount of blood-borne infections may still be transmitted. But on the other side, it is very costly. The lesser amount of dose is required because of the greater half-life. So 20 IU per kg infiltration near the wound generally suffices the purpose. So more about rabies immunoglobulin, how to inject. So when you hold a vial of rabies immunoglobulin, just take it out from the fridge. Please bring it to room temperature before you inject it into the wound. Bring it to 26 to 30 degrees centigrade, what is recommended. Maximum dose, as I told you, maximum dose is to be injected near the site of the bite. Do not give RIG to the patient if the patient has presented late to you. Like he was in a very peripheral area. Generally this forest people, they generally stay months together in a very remote area. They have gone on patrolling outside to look for the counts of wild animals, and they have come back, and then after 7 days at some peripheral MI room, they have already taken 3 shots of their vaccine. Now they have come and asked at the 7th day, can I take the immunoglobulin? No, because by that time already the immunity to this vaccine has already started developing. Giving RIG is just a wastage. So do not give RIG if the patient has already completed 7 days of vaccination. That is, he has already taken 3 vaccines of 0, 3 and 7. Secondly, the patient has already been immunized earlier. That is, he has already received a pre-exposure or a post-exposure prophylaxis containing 5 vaccines. You do not inject him with RIG because it is again a wastage. The antibodies to the virus already exist in his bloodstream. All this, I'll come to that. And then after you have injected RIG, the patient has to be observed for 15 to 20 minutes in the emergency department prior to discharge. Now, what are the complications of giving RIG? Apart from if very low rate of anaphylactic reaction that can occur, the other is serum sickness, because you are giving heterologous and autologous serum. There is a small percentage of chance that the person will end up with serum sickness. The person will present with fever, arthalgia, and malaise. So this majority of them can be treated with paracetamol and antihistaminics. However, few patient does develop life-threatening serum sickness requiring what? Requiring further management at a higher center. Passive immunization, again, we have discussed about equine rabies immunoglobulin, we have discussed about human rabies immunoglobulin. Now we talk about something which was granted to us by Dr. Kohler in 1975, that was monoclonal antibodies. Now monoclonal antibodies, you will find it has right now expanded in such a way that it is covering all the entire spectrum of medicine. So we do have a monoclonal antibodies available in India. It is manufactured by Zydus Cadila. It comes in the name of Twin Rab. It combines two monoclonal antibodies. One is Docaramimab and the second one is Myromamimab in the ratio 1:1. Generally it comes at 1 ml, 2.5 ml, 5 ml vials, and the dosing is 40 national international unit per kg. So what happens is कि it generally omits the requirement of a major setup, that is bringing in horses or bringing in humans. No ethical problem is there. Like if you recruit humans for draining out autologous serum, so there are a lot of ethical problems that occur. So these are manufactured basically in labs, and we get this monoclonal antibodies, and then the maximum, once again the maximum portion of it is because they are neutralizing the virus. So maximum portion has to be within the wound. So now we come to the active immunity. Majority of the vaccines available in our country are cell cultured vaccine. The potency of the vaccine is the most important thing. The potency, when you take out a vial or a vaccine ampule, you just see the potency. The potency will be written as greater than 2.5 international unit. Now, there are companies which dissolve the vaccine in 0.5 ml. They give the diluent along with the vaccine. So they are freeze-dried vaccines, so some of them will be dissolved in 0.5 ml and some will be dissolved in 1 ml. So don't get confused between all this. The potency, whether it is getting dissolved in 0.5 or it is getting dissolved in 1 ml, the potency of both the vaccines remains the same. So whenever you are writing a prescription, just write one vial or one ampule IM stat on the deltoid, right? So potency of all the vaccines, whether it is being reconstituted in 0.5 ml or 1 ml, remains the same. The vaccines again are to be stored and transported at 2 to 8 degrees centigrade. The cold chain has to be maintained. Once you have reconstituted the vaccine, please do use it within 6 hours. And once you have reconstituted it and you are thinking that you will use it later, so you have to keep it again back to in the door of the refrigerator from 2 to 8 degrees centigrade. So how can we give the cell cultured vaccine? Now there are two major regimes. The regime that I follow in my institute is an intramuscular route, which is also known as the SN regime. ESSEN, SN regime. In SM regime, depending upon the manufacturer, it is 0.5 to 1 ml. It is given on the deltoid. Because of the presence of the fat on the gluteal region, it should be avoided and it should be given on the deltoid. For kids or having people with less body mass, it should be given on the anterolateral part of thigh. How it is to be given? It is to be given deep IM. When it is to be given? It is to be given on 0, 3, 7, 14 and 28 days. So these are 5-day regime, one site of vaccine, the full ampule is to be given. Neutralizing response of antibodies is within 10 to 14 days, and after giving the vaccine, you observe the patient for 15 to 20 minutes. Intradermal route, Interdermal route, now what happens is ki the amount of vaccine required to generate the same amount of immunity decreases. It is around 0.125 ml. Where is it to be given? Now this is the most important difference between the intradermal route and the intramuscular route. Intramuscular route, you have, for every day you have to give just only one prick, but for the intradermal route you have to give two pricks. Where are these pricks supposed to be given? This prick is supposed to be given 1 inch above the insertion of the deltoid. How is it supposed to be given? The same procedure as we give BCG is supposed to be followed. This 1 ml with the beveled edge upwards with an insulin syringe, you have to raise a blade of 4 millimeter in size. That is the ideal condition in which the intradermal injection has to be given. So for every days, on 0th, 3rd, 7th and 28th day, 2 injections will be given on either deltoids. Mind it, for intradermal route, 2 injections are to be given on the either deltoid. Neutralizing response, again in 14 days. Now what is this neutralizing antibody response? If the facilities are available, you can check for the anti-rabies antibodies. The ideal route should be 0.5 IU per ml. If the response is there, that means the adequate amount of immunity has been generated by the person. Okay, now comes the question. My patient has already received a full course of PEP or pre-exposure prophylaxis previously. Now what? First and the foremost, as I told you, for every bite, the wound management is of prime importance. The whole management lies in wound management, ideal wound management. Then intradermal injections only at one site at 0 and 3 days. IM injections, because we are following the IM variety, on one site 0 and 3rd day. No RIG is supposed to be given in a Cat 3 bite also. What is a pre-exposure prophylaxis? Now normally this forest people, when they they are generally given a pre-exposure prophylaxis. So we follow 0, 7 and 14, 0, 7 and 28 day, 3 days prophylaxis regime. And in ID, if you follow the intradermal variant, 0, 7 and 28 day, both are same. And only thing which is different from the post-exposure prophylaxis of ID variant is, it is only one site. Now we come to the question that patient had already started the vaccination but he defaulted in between. So what am I supposed to do? So if he has completed the first 10 days of vaccination, that is he has already completed the 0, 3, 7 day of vaccination, and he has come to you after the 10th day of the vaccination, it is safe to assume that he might have already developed some amount of immunity. So you just continue the next 2 booster days. If he is 1 or 2 days less, just try to adjust and give it at a 14 days interval. That is over. But if the patient has defaulted on the first 3 doses of the vaccination, you will have to reschedule the vaccination again. But vaccination should not be denied. The vaccination has to be restarted and has to be continued. So I have reached to the end of the presentation, and if there are any question, you can ask on the live chat. Questions? Okay, so when you don't have any questions, let me ask a few. Sir, my patient is suffering from HIV or is on high doses of prednisolone or has already received an organ transplant and is on immunosuppression or is on balanced immunosuppression. How do you think I should go about in vaccinating the patient? Pregnancy, breastfeeding, organ transplant, HIV. any rheumatological diseases requiring immunosuppression, the vaccination, that is the active immunization, should not be denied to any patient. You have to start the patient on active immunization. If you have got the facilities, please do a antibody assay, that is anti-rabies antibody assay after the 10th, after the 3 vaccines of 0, 3 and 7. Reassess. If you have to give some boosters, then follow it at after 28 days with every 2-weekly interval till the time the person develops adequate immunity. Have you understood? You do a antibody assay, you find that it is less than 0.5 IU per ml, then you again inject after 28 days, after that is at the 45th day you again inject, then again at the 60 days, so that the body develops some amount of active immunity. So with this we have come to the end of the class. If there is at all questions, you can leave it on the chat. I will see and reply to you personally. Thank you all.